You're listening to Aging Uncensored.
Okay, welcome to Aging Uncensored, the podcast where we dive into everything aging, perimenopause, working with friends, all the things that happen while you're getting older, and we're taking care of older people and raising teenagers, doing all the things. So I'm your host, Christy Baines with Life Care Solutions, and I am super excited about our guest today. She has been a longtime friend and definitely my go-to everything geriatrics clinician, all the things. Wow. And I probably will get teary-eyed in a little while because you and I have had some really, really heartfelt, serious conversations in many moments. But so excited to have our guest today, Dr. Marianthe Grammas.
Thank you.
From UAB, University of Alabama, Birmingham. And she's going to give a little bit of a background of how you got to UAB, what you're doing, and then we're just going to jump in.
Sounds great. Thank you so much. So excited to be here. And as I said to you a minute ago, I may get really uncensored, so hopefully I behave myself. But when I start to get passionate about these topics, sometimes things fly out of my mouth. So I am a native of Birmingham, grew up here, and did all of my education outside of Birmingham. Trained in internal medicine and pediatrics as a resident, and during that residency actually had the opportunity to work with some world-renowned geriatricians in New Haven, Connecticut, and never thought I would fall in love with the field of geriatrics, but I 100% did. Had some kind of pivotal experiences with a couple of mentors there, and really just learned that I loved meeting people where they are and looking for ways to optimize their health, their well-being, their quality of life for that, final phase of life for however long that is. So I did a 2-year geriatrics fellowship and elected at some point I finished the pediatrics part of my training, but I did not complete the board certification for that. Landed myself back here in Birmingham in 2013 at UAB. Wanted to get back home to where family is, and have been on the faculty at UAB since I started in 2013, doing initially outpatient and inpatient geriatrics, and then kind of found a niche in home-based care, and that's where I spend all of my time now.
Which we love.
Yeah,
we absolutely love.
Yes,
so,
love.
I can remember the first time I met you. We were in the clinic with one of my more colorful client patients. And we knew then that we were going to get in the trenches with each other. So,
100%.
Wherever it was with that patient. And I love what you just said. What resonated with you in your geriatrics fellowship was meeting the patient where they are.
That's right.
And that's really what the whole goal of geriatrics, home-based care, care management, that's what we do. We meet them where they are versus sticking them in some very sterile clinical situation and saying, oh, with a perfect world, this is what you're going to go do. And then we're going to send you on the way and you do none of those things. Right?
The pivotal kind of event in my training, so I was a second year med peds resident at Yale, and Mary Tonetti was my attending on the inpatient geriatric service. So Mary Tonetti is known all over the world for her work in falls in the elderly. She was the first person to define it as a geriatric syndrome, something that had risk factors, that had predisposing factors, precipitating factors, and that there were some very preventable things that we could do. And then spent a lot of her career developing policy around falls. But anyway, she was my attending on the wards, and typical kind of resident service. We had been on call, we were presenting our patients, and these were all older adults. And so at the time, that we did not do bedside rounds. We did rounds outside the patient's room. So we spend, all this time talking about how the patient presented, what their problems are. And this was a lady, the patient was a lady who had been in the hospital several times, older female, lots of the labels being thrown around, non-compliant, doesn't take her medicines, doesn't adhere to the diet, was in there for a heart failure exacerbation or something. And so we had given all that stuff to Dr. Tonetti, shared all that. And she just said, okay, guys, we're going to go in the room and I'm going to lead the encounter. And she walked into the room and she asked the patient if she could sit at the end of the bed. The patient said yes. And she said very kindly, we've spent a lot of time outside the room talking about your health and the things that have brought you into the hospital. But before I really kind of, talk through that with you, I want to know what matters most to you.
Oh, I love that.
Yeah.
Wait, what?
Right.
You're going to ask a patient what matters most about their life? Mm-hmm. Well, why would you do that?
What matters most to you?
Right.
And how can we help you? Because there are a lot of things that we know are sort of problems right now affecting your health, but I don't know if any of those things are the thing that matter the most to you. And honestly, what she shared with us was just profound. And the various factors that were playing into her inability to be, quote, compliant with the regimen had nothing to do with her lack of desire, lack of interest, cognitive impairment, or anything like that. But they were very important factors for us to address, because if we didn't, no matter what we told her to do, it was not going to work. Right. And so I just loved that, because it reshaped the way I thought about patient care, that and not even only for older adults, but if you don't think about the person holistically and ask them what they value and what matters most to them, then you can have what you think is a perfect plan and it will fail.
Absolutely.
So that was my...
Taylor, the podcast name for this program is What Matters Most to You. I love it.
All right.
Yes. Nice. See, this is how we do this.
And we'll get into home-based care eventually,
yes,
right? Okay,
absolutely.
Cool.
Of course we will.
But if we don't, that could be another podcast. So we never know.
Well, that's what happens, is we just continue talking on this, and then we have multiple podcasts.
100%.
Or multiple episodes is what I should say.
Yeah.
Well, I love that. And and hearing that conversation and listening to your story, that is exactly what I've experienced with you for the 12 years that we've known each other and worked with patients and so forth. Again, we've seen this with our patients, and I just have to share, because I think it's important for our listeners to hear this. Again, I said this in the introduction, that you and I have had some very serious conversations related to my family members.
Sure. Mine too.
Yeah. I mean, we're just one big family.
That's right.
I really want to be adopted into the Greek family, honestly, because I really want your food and all the fun parties. And this year I am going to the Greek festival, so love it. But yes, we have shared a lot of helping each other out, and family members, and two conversations specifically regarding when we bring in hospice. We had those conversations about my aunt, my beloved Aunt Jean, that you helped me with, and then my dad. Right. And in both of those times, the way you presented it to me, and even though, I work in the business and all those kinds of things, it was just such a comforting, and there was just this peace that you gave the family on how to present this to the family.
Right.
And it was looking at the whole person and what mattered most to them in the moment. And so, specifically with my aunt, who had been battling stomach cancer and had a number of different things going on. I think they were wanting to continue to give her some massive amount of iron, and it was terrible. She hated the taste. She was in the hospital. And you and I had the conversation, and and I'm going to mess up the term for it, but that was the first term I'd heard, the first time I had heard cancer cachexia?
Cancer cachexia.
Thank you. And so I'll let you tell us about what that is, but, we were trying so many things to help her, and the way she is she never wanted to disappoint anybody. But her body at the time and her heart at the time
Yeah.
was, this is not what I wanted to do anymore.
Yeah.
And so, explain what that is.
Yeah. Well, so cachexia is basically a condition or a state that somebody can develop with any chronic, serious, life-limiting illness. And we often associate it with malignancies, cancers, especially once they've become more widespread or metastatic. But you can also see it in people with very advanced heart failure or COPD, or
could it be like a neurological, like ALS or some of those too?
Right. Yeah. So basically, it's related to. I mean, I probably am not going to speak to all of the physiology of it, but just think about it when people are in a state of health, then they're able to, like, the energy that they are consuming is able to fuel their activities and things like that. When people have a serious illness or something that is growing inside of their body, well, that thing needs to be fed too, right? The cancer, the tumor, or all of the energy that's being expended to, like, breathe better or to, walk around when you're exhausted from heart failure or COPD. So it is almost impossible to gain weight, much less to sustain weight. So you'll hear people say, I'm hungry, I'm eating, but I can't gain weight. And then you just see them kind of gradually, like, melting away.
Yeah.
And that's cachexia, really, where it just kind of looks, I mean, it's an extreme form of malnutrition, and it's related to, serious, usually life-limiting illness.
And it's not that patient, like in my situation, my Aunt Jean wanted to, like, it's not giving up. Her body was just saying, you know what?
Yeah.
It's enough.
It's a marker of extreme frailty.
Yeah.
And frailty is a predictor of mortality. And so
absolutely.
I think that, the thing about knowing what matters most to patients, and I mean, I think that any clinician can do this. I think sometimes, we have so many competing priorities in medicine, and if depending on the setting in which you practice, I mean, I'm blessed to be able to do home-based care. So I have the luxury of more time and the space of a person's home where they feel safe and relaxed, but so I can have these conversations. The return on those conversations is huge because it really helps you to know how to direct the focus of care. If you know what matters most to patients, and kind of what they're willing to go through for certain outcomes, then you can be more intentional about what you expose them to or have them go through. Being a geriatrician, I think it's important to be that person who's like the quarterback of their care, 100%. And to have the 30,000 foot view from the sky of everything that's happening and knowing where all the pieces of the puzzle are, because it is so easy for our patients to get so lost in the system. Care is fragmented because they may have multiple providers, they may have several pharmacies, they may see specialists in one system and then a primary care doctor in another system. So we don't have a unified medical record. And so there's lots of different ways that there can be fragmented care. But even if people are, well-meaning and doing the very best that they can, most people operate within their scope or their lane, right? So if you're a cardiologist, you're primarily going to be focused on the cardiac issues. If you're a pulmonologist, the lung issues. If you're a nephrologist, the kidney issues. And it's so important to have someone, and it could be the primary care doctor, the geriatrician, or it could be the person who knows them best from whatever their most serious illness is, to just take a wide view of the whole picture and say, what are we doing?
Right.
What are we doing? Why are we doing these things? And is this in line with the patient's goals? Have we even asked them what their goals are?
Right.
Do they know what their options are?
Yep.
Because a lot of people don't. They just do what they do what they're told because they think that's what they're supposed to do, and maybe they're even afraid to ask if there's another way,
Absolutely. So we made the decision to, cut out all the things in the inpatient setting for my aunt and take her home with the hospice company that took care of her husband. And I remember going back to her bedside and saying, Aunt Jean, guess what? You're going home tomorrow with the nurses that took care of Uncle Sandy. And she was like, did you hear that? Have you heard that? That is the most beautiful thing I've heard. And I'm like, But again, it was looking at the big picture. And so going through that experience and what you've learned from, all of your experience in Connecticut, Yale, UAB, here we are. Let's lead to home-based care.
Sure. Yeah, so that was a very organic process that unfolded. I did have exposure to home-based care when I was a fellow in geriatrics at Yale at the West Haven VA. So I know Dr. Duxbury was on, not too long ago talking about home-based primary care through the VA system, which is I would say kind of the parent of home-based care in this country, and has been around for probably 50 plus years or so, and is a fabulous model of care. So I had that exposure as a fellow when I had a small little panel of patients that I got to see, when I was there. But then I got to UAB and I was primarily doing inpatient geriatric consults and then seeing patients in the ambulatory setting at the geriatric clinic. And what I noticed was that there were people that were falling through the cracks. Yeah. And I would see people in the hospital who I felt could have not had to be in the hospital if they had had better access to primary care. And it wasn't that they didn't have a doctor. It was that, they couldn't get there very easily, potentially because of the physical burden of getting there, or, they waited too long and they tried to do all these things at home, and then it just, an emergency unfolded. And so they would end up in the hospital, and then bad things happen in the hospital, right? 100%. So you go there for one thing and you're there for, 10 days and you now have, 3 new problems, and you're going to go to a nursing facility afterwards.
Right. And then you're going to get more
problems. And then the other thing was that we would see that people couldn't, we would have no-shows in the clinic or frequently canceled appointments. And, so I just decided after having some of that happen that I thought it would be, and we did have a few patients that Dr. Duxbury and one of the nurse practitioners had kind of seen on an informal or an ad hoc basis at home for several years. There wasn't really a fully, fledged out program for home-based care at UAB, but they were doing it along with some other physicians just kind of as needed to be okay with refilling medicines and whatnot. Right. But I said, let's see if we can find some patients and intentionally, go out there and see them, and really with the goal of trying to improve their access to care and keep them out of the ED in the hospital.
Sure.
So that was in late 2014, early 2015, and Chaley was the nurse practitioner that I worked with, and she was pretty fresh out of NP school and very, eager to kind of do whatever and explore, the possibilities. So we started it, and within a year had seen, I think, 70 patients or so in this way, and were able to demonstrate really good outcomes for those patients, including a very, significant reduction in emergency department utilization and hospitalizations and readmissions. And so we were able to then begin to grow what is now a more, fully evolved home-based primary care program.
How big is it now? What's your panel now?
Our panel is holding at a steady state of about 300 patients, but we have a wait list of about 100 patients.
Wow. Okay.
And in the years since we began, we've touched almost 2,000 lives.
That's amazing.
So we are not able to grow any faster because of basically the bandwidth of the team and the program. And as I tell, and this is sort of the truth across home care medicine in this country, is that one home care patient is like having 2 to 3 usual care patients in a clinic setting, because the load of work required to take care of these patients is just so much different. Right. From a medical side, a social side, a care coordination side. But that's kind of where we're at right now.
Because you're taking care of the whole person.
Correct. Right.
Which is the whole model, right? So you're bringing in, y'all have got a team of social workers, you've got a team of nurse practitioners, you've got a team of nurses, you've got the whole aspect, and you're looking at everything. Right. Because once you go into the home, you never know what all you're going to find.
Correct.
Right?
That's right. And I think that, the model that Dr. Duxbury described with the VA is like pie in the sky, because you have a single payer responsible for the medical care and the cost of all those patients. So they understand what a dream. They understand why it matters to do everything that you can for them, both from like the what's best for the patient and the care setting that they're in, and also what helps the system.
Right.
It does not drain the system, right? Our system is not set up in 2025 to take care of the very complicated, medically complicated, socially frail, functionally limited people who live longer, not necessarily with better health, but definitely with a lot more morbidity and functional, like
the amount of complexities that go into everything, and
so they have it great because they have the resources that they need to do kind of all the things for the veterans. In home-based care that's not affiliated with the VA, there's lots of different ways to kind of craft programs, and it sort of depends on what your practice setting is, and if you're in a fee-for-service model or if you're in a value-based care agreement and an ACO, or concierge medicine, which is not at all what we do.
Are y'all considered like an ACO?
UAB is, UAB is part of an ACO, but there are other ACOs that are specifically looking at the care of patients with more complex or high needs, and so those are almost like an arm of an ACO, but it's a separate.
It's like where they did nephrology, they've done some things
potentially, they
breaking it out.
Yeah, and so those are looking at, they almost, what they do is they kind of carve out from, let's say, a bigger ACO or primary care practices that have a population of patients with many more complex, like medical needs and social needs, and they have higher HCC scores and things like that, and so the payment model is different when you're in an arrangement like that, because you get paid both kind of on the front end by the organization that you're partnered with to take care of these patients. So it may be like a per member per month sort of model where, hey, we have 150 really complicated patients who need a lot of care, and they can't really access care the way other patients can. Right. So you do it in a home care setting, they give you kind of an upfront per member per month, which helps to sort of fund the, some of the unique aspects of a home-based care program. And then on the back end, there's shared savings too. So you may receive,
you keep them out of the hospital.
If you are able to reduce the total cost of care of the patient, by doing everything that you can in a lower cost environment, then that could be, another, sort of financial, that'd be another source of income to the program, as you, you meet the agreed upon measures and, do what you need to do to reduce the cost of care and stuff like that.
Do you think we'll be able to see more of these type programs develop in the next few years? Obviously, we can do that in Jefferson County where we are here in Birmingham and things like that, but you think about rural health, you think about other things like that where people have a really hard time getting to the different specialists and so forth.
Well, I will tell you that when we went to the American Academy of Home Care Medicine annual meeting in Phoenix last October, the keynote speaker, who has a podcast, and he's written a lot of books. Podcast is, I think it's like Transforming Healthcare in America. And it's Dr., I always misspell his first name, but it's like Zeke Neuwirth.
Okay.
Anyway, he gave a wonderful keynote address, and essentially the tagline was like, home care medicine is a must-do, can't fail in this country. And the reason is that it is not only a model of care that improves patient outcomes, it also is going to be one of the key pieces of some of the financial crisis that this healthcare system is in. And I think one of the things that, we had talked about, maybe me discussing, is who is appropriate for home care.
Absolutely. I was going to ask that question.
And so, historically, people thought of home care as, we're not going to talk about like what it was like, in the 1800s and early 1900s with the doctor in the bag. We're like,
I just finished 1923, and they were very important to have the doctor with the bag.
Yeah, that was like done out of like for a different form of necessity, because they did not even have clinics or hospitals, right? Yeah. And so the only way to get people care was to go to where they were. But now there's kind of what everybody might think about, which is a frail older patient, right? Who like maybe they have dementia, or they can't walk very well, and they're homebound. It takes 3 people to get them out of the house, and they're exhausted. Everybody's exhausted. Okay, so there's that, like we call like that the frail elderly, or sort of the geriatric homebound population. And then you have people with disabilities that are either congenital from birth or acquired. So this could be people with muscular dystrophies or cerebral palsy, who go through pediatric care and then become young adults, and they need, ongoing care. And there are even pediatric home care programs across the country.
Really?
So, but, so you have people with, congenital disability, and then acquired through, maybe stroke or trauma, spinal cord injury, head injury, and then you may have other neurodegenerative conditions like ALS or MS. So we've got a lot of that. And then this third group, which is I think where you see a real opportunity with value-based care and ACOs, is what people may call either high needs or high utilizers. And this is a group of patients who may be dual eligibles, who are, medically complicated, multiple chronic conditions, advanced stages, high social determinant, lots of social drivers, food insecurity, medication affordability issues, low social support, low health literacy, all the things, right? And then they, for a variety of reasons, just do not fit into the box of healthcare that we have. Like they're the ones that, people are always frustrated to take care of, and they say, oh, they don't take their medicines, and they're in the ER all the time, and they don't take care of their diabetes. And it's not because they don't want to. It is not. It's because there are so many variables that negatively impact their ability to manage their diseases. So this is a growing area in home care medicine where we take care of folks who are homebound. I mean, they need specialty care, but they are not able to access it well. And so that's a population that we are growing in our program, and that's 40 to 65 years of age. And they have their life expectancy is limited because they've got advanced kidney disease, poorly controlled diabetes, they already have heart disease, they may have wounds. I mean, it's a variety of things, right? And so but they're spending so much time in the ER and the hospital. And so that's another place where home care is really, kind of finding a niche. And I think that it's meeting people where they are, as we said before. It's understanding what matters most. What are the goals? What are the resources for the family, for the patient? And how do we best support them?
Because you can provide what you can provide in the home is so much more for like tactile learners. You're in their home, you can demonstrate what needs to be done. You can see exactly how they're managing their medicines, if they're managing their medicines. I mean, I know I miss mine on a regular basis.
Sure.
I can't imagine if I took, 20 meds and a few of them the doctor's trying to titrate up, or forget the Coumadin schedule and anything else. And then just simple things as to, like you said, how do you access things such as prescription savings and utility and transportation, meals, all of those things. There are a lot of great services out there. Just a plethora of services. But the end user may not have access to internet, may not know how to fill out an application, not to their fault. It's overwhelming. And, most of these things, you start it and it's not user friendly. So what are you going to do? Forget it.
Right. And, people are always talking about how, and it is true. We spend more money in the United States on healthcare than any other country in the nation, and we do not have the best outcomes.
Nope.
And it's there's lots of reasons. I would say with confidence, one of them is that we are not addressing some of the very basic Maslow hierarchy of needs kind of things and the social drivers. And we are very much a reactive healthcare system and not a proactive healthcare system. And all of us as like consumers of the system have become used to this model. And so we think it's the way that we should do things. But like it kind of needs to be blown up and rebuilt.
100%.
And I think that like in home-based care, you see all the things, right? You see the medicines, you see what's in the fridge or not, you see what it takes to get to the house.
Yep.
You see all the hazards of the home. You know what the social support is or isn't. Just so many things. The lens is just so clear. When you go into somebody's house, you can answer. I think Chaley said this on one of the other podcasts. You could have 100 clinic visits with a patient and not get as much information as one house call, where you might spend 60 minutes and it just all becomes so clear.
Absolutely.
And so the return on investment there is that suddenly you can grab all the medicines that are in a messy state and fix them up, right? You can put them in a pill box, you can deprescribe, you can talk about advanced care planning, you can do goals of care conversations, you can connect them to the right resources for social support. I mean, it doesn't happen overnight. It takes time. But you can begin to chip away at those things. And like I said, I mean, we take care of people at UAB House Calls across the socioeconomic spectrum. I mean, we don't, it is, I've taken care of people in every zip code within 30 miles of UAB. And I've seen. It
can be a $3 million house or a $30,000 house.
That is correct. That is correct. And so I think that there is a place for doing home care in any of those areas. I will say, I think that you can just, like he said, it's a must do, can't fail, because I think it is going to be part of the solution. And it's not only primary care. I mean, I tell people we're like primary care on steroids.
Sure you are.
Because we do a lot of procedures in the house. We can get labs. We can do imaging. We partner with a lot of specialists to really try to consolidate or streamline specialty care. We leverage telemedicine as much as we can. We use video and digital imaging, and we use all means of communication with patients.
What do y'all do when, let's say, the home doesn't have internet? Do you have something you bring into the home for that? Okay.
Yeah. So we have, we basically have like a little mobile office that we take into the house.
That's
so
cool.
We all have all the providers and interprofessional, team members have their own laptop. We have our own portable like Wi-Fi.
Sure.
We
like
have
a hotspot or whatever.
Hotspot. Yep. We have mobile phones. We have stools that we carry in with us that are like collapsed, like telescoping stools, so we can always know we have a place to sit. And can be as close to the patient as we need to be. So yeah, that's part of it. And we take what we need from just kind of doing basic things that you would expect, like vital signs. But we also have wound care supplies. We do ear care, we do foot care and podiatry. I mentioned before, we do lab draws, we can do some injections and things like that. And we're always at our program, we're always looking to see like who can we partner with next to expand services.
Speaking of partners, I was getting my eyes checked and Dr. Patel.
Yeah.
So she and I were talking. I'm so excited about her new clinic that's in Pell City, but she said that she had been talking to you about some telehealth things, that, obviously not like a full on eye exam over telehealth, but things that you can describe to them and then kind of help direct you on, if there's certain drops or ointments or whatever that need to be done, which I think is so cool.
Yeah, that's a great example. And, we've talked for a while with one of the faculty at the dental school about the need for some mobile dentistry services.
We needed that last week with one of our clients.
Yeah, I think like that's a good segue to something that I try to communicate to providers who are maybe a little weary of the idea of doing something at home, is that, not having care is not the answer. Right. So while I understand that being in somebody's house is not the ideal setting.
We've
for
been in
all
some
things,
interesting
right?
ones.
Right? Yeah. I mean, it's not going to look like your clinic room.
No.
However, if the patient gets no care because they can't get anywhere unless they have to pay $1,000 out of pocket for an ambulance that may or may not get them there on time.
Usually not.
And then they get there and like everybody's mad at them because they didn't show up on time. You know, all the system barriers to like making it work. So, patients are very grateful for the opportunity to have access to care,
Absolutely.
whatever that looks like. And they understand that, you know, doing it at home may look different. They may not have the full spectrum of services available to them, but that still meets a need.
It's way more than
That's
having
right.
nothing.
Right.
You
To
know?
say, you know, I mean, and I've been so blessed at UAB with finding champions and lots of the different specialty fields who are willing to think outside the box, because that's what you really have to do in this field, is to think outside the box and be flexible and come up with creative solutions. And you know, your patients are, I've never had somebody tell me that they would not, you know, that they're always grateful. And they like, you know, they continue to ask who else can come to the home. And I said, well, you know, we may not be able to get every specialty coming to your house, but if we can at least get them to like help us with the telemedicine things, or, you know, maybe we pick a few that might be willing to come out periodically when there's enough volume.
Sure.
That's it. Right.
Have you ever had a situation where you're there with, you know, patient Mrs. Smith, and Mrs. Smith's spouse or family member is ill, and you, I mean, what do you do there? Like, how do you can you help that other person?
So we have a lot of couples that we take care of.
So that makes sense to have them both. Yeah.
Sometimes we go out there to see one person and we notice that there's another person in the house that may benefit from the same type of care, and so we'll bring it up to, you know, whoever the responsible party is, to see if we can't get them connected to our program, or, you know, encourage them to, you know, talk to their healthcare provider about, you know, whatever it is, maybe it's home health or something that they need in the meantime. And then we also have situations where, you know, people who are homebound, it's obvious when a patient is homebound.
Right.
What's not always apparent to everybody is that sometimes the caregiver is also stuck. And so the caregivers are not getting to their appointments.
Nope.
And their health is declining, or they're walking around on a painful hip forever because they can't get to where they need to go, or they're struggling.
They've thrown their back out because they're helping their loved one.
That's right. And then, you know, maybe they're depressed or they're not sleeping well, and so they're struggling and they can't get what they need. So we've actually started thinking about, you know, when we have more availability and like provider, you know, capacity, that we may, you know, on a sort of select basis, look at, you know, at least for a temporary period, trying to offer some services to the caregivers. It's not the right, you know, it's not the right model for everybody, and I don't want to deprive anyone from going into a clinic if they can. But again, if they're not going at all,
it's better than
because they don't want to leave the house,
right?
Then, or they, you know, they don't have a respite option, they don't have anybody, they can't afford somebody to come in and sit with the person.
No,
or
that's the most expensive care out there. I can't afford it.
Right. So like, that's another place to say, you know, because if that caregiver goes down, that patient is going to be in a bad way.
Yep. I call it a three-legged table. Three-legged table.
Yep.
And, you know, one of the things as care managers, we always focus on the primary informal caregiver, whether that be a spouse or, you know, a daughter, son, whatever. But particularly when it's a couple, you know, or at least, you know, two people living in a home, we look at both because, like you just said, the person that has all the chronic issues usually is getting more attention than the primary caregiver. And the primary caregiver is going to have an issue. Depression, heart attack, stroke, whatever that looks like, because the amount of stress. You know, what is it? You know, being a family informal caregiver can take 7 to 10 years off of your life expectancy. We see this all the time, which is what I'm real excited about the guide program. And we've talked a lot about that we can finally start looking at that that informal caregiver.
One of the things somebody asked me once, like, how would you in a word define like who qualifies for home-based care? And this is not 100% true, but I would say, if I tell the residents and the students who are working with us a lot, if your patient is showing up to your clinic on a stretcher and they had to come by ambulance, then they probably could benefit from home-based care, especially if that's happening a lot for them.
Or if you see them canceling over and over
again. That's right. Or if they're in the hospital all the time for something that like it just is not adding up, those are people that you could.
How do you think y'all can get to the 100 waiting list?
Well, so some of that we're looking forward to in the fall having a new provider who is raised as a UAB resident who will be graduating and joining our program. So that's
under the family, family member
knows the program, knows the ropes. I think the key, and I mentioned this before about how you pay for these programs, because we're in a fee-for-service place right now, and I think that fee-for-service is not sustainable. And I think that other places in the country, you can't have like 1 foot in value-based care and 1 foot out, because really you got to be all in for value-based care.
Does it have to do with state to state where the what insurance is paying, what it's looking like? What drives that?
I don't know all the things about it. I
know
that
they start going to like policy summits or something.
I know that to get into value-based care, like the upfront investment is pretty huge, because really what you're talking about is a care model that addresses the whole patient.
Right.
So it's not as much about anymore like how many visits you can churn out a day, right?
How many add-on minutes you can do.
Right. Yeah. It's not about that. It's like, okay, we have this patient with these, 15 different issues. Mm-hmm. What can we do to take care of this patient so that they're compliant with their medicines, the critical diseases that are affecting them are improved in management. They're spending more days at home and not in the ER in the hospital, because we know that that's better for them, and that they have like the support system in place and social services that they need, right? But the upfront there is that you're going to have to start investing in things. Right. It's going to cost money up front, right? And the return may be a little bit later. And I think it's harder for some people to see that, when it's much easier to say, oh, let's build more rooms in the emergency department, or let's hire more of this type of doctor who can do this procedure that makes so much money for the the health system. And this is across the country issues. This isn't like just a thing in Alabama, right? I just think that some places have caught on faster, especially where access to care is even worse because of long spaces between healthcare centers. So out in the, Intermountain area in the West, and like, parts of California and the Pacific Northwest. And so where there's more like population density, I think it's like a little bit harder to see, but I mean, Manhattan's had it figured out for 30 years. Yep. They just do it like area, in the boroughs or whatever, one of the best home care programs in the country is in the DC area. It's called MedStar. Really? And they may be in other places too, but ChinMed, I think, is down in the like Florida area. But so I think that it's just aligning goals for the organization and figuring out kind of, what do you want your mission and your vision to be, and how do you want to like attack it?
Do you think there's a possibility, because right now, what do you have, like a 30-mile radius from UAB?
So you asked about how we're going to get to the wait list. So the answer is that we have to have more providers, right? Because we can't take on more patients without having providers to take care of them. And then with, once you start adding 100 more patients, then that's going to be you're going to need social workers and nurses and case managers to, again, because it's the complexity of these people is I go and I do a visit, and then there's like a whole bunch of work that's got to be done for that patient after my visit that doesn't have anything to do with me.
Right.
So I think once we can get into these value-based care arrangements, which we're actively working on and pursuing, and we have a better financial model where we can get, those per member per month payments, and
you
then
can
have
get your staff paid for.
That's right. It won't take long to get to kind of become at least neutral, or not maybe even profitable.
Right.
Because the types of things that you're talking, like you really need somebody who does behavioral health on the team, because
100%.
So much of what we see is mental health, emotional health, caregiver strain, right? Depression, dementia. So you got to have that. It would be helpful to have somebody in the nutrition field, pharmacy, some of these things that the VA has, right?
Yeah.
They're a single payer system. But if we could have the funding that we needed to pay for some of these additional services, then you start really attacking, issues.
Right.
And then of course, being able to leverage technology and do more through telemedicine, remote monitoring, and expanding your reach, even if you can't physically get there, but you could maybe provide, remote health, care, and possibly like some of our patients now we see quite frequently because we can, right? And they need that. But if you're talking about a more rural area where you can only maybe go once every 6 months, but you could do televisits every month.
Yep.
Right. And they're still getting care, because right now the care they're getting is like in the ER or in the hospital.
Yep.
So,
if they can get there.
If they can get there.
Right. Absolutely. And you see, and I've seen we've been out talking about guide and things like that, I'm seeing more rural health doctors really adopt the value-based program. There's Julia Booth. She actually went to high school with me. She is in Pickens County.
Yep.
And she has a very productive, really efficient ACO in that area. And that whole area is nothing but rural. And she has a whole team about it.
Yeah.
But that's very forward thinking. Most people aren't thinking like that.
Yeah.
And again, it's that from a business model perspective, it's like, can I take on that cost in the very beginning, knowing that it's going to be several months before I can see this being paid for?
Yeah. Well, the other thing is, if you're on the hook for their care, their cost of care, then you've got to have all the things in place to not only manage the primary care, but the acute urgent care, right? So right now, I think at UAB House Calls, we do a really good job of leveraging we have nurses that can go out into the field on acute, occasions. We partner with home health companies.
Yep.
We have the mobile imaging that we can use. We can do some home antibiotics. We can do, some IM or IV diuretics if we need to for a short period of time, treat some COPD exacerbations in the home. But you've got to be able to triage we change peg tubes at home. So where some people peg is dislodged or it's clogged, ER. You call your clinic and they're like, oh yeah, you're gonna have to go to the ER. Nope. We had one this weekend when my nurse practitioner, we have this emergency peg out kit that we've created. So my nurse practitioner coached the caregiver to put the emergency to use the emergency kit, and then she went out the next morning and replaced the peg tube at home. So otherwise that would have been a several $1,000 trip to the ER.
And a full day and a half, if not
Correct.
2 days for that family.
Right. And sometimes these people, like we've talked about before, they show up for one thing, right?
Yeah.
And then while there, we're going to check all your labs anyway. And then,
all of a sudden,
it's like
all of a sudden you're in psych because you had a UTI and you have a behavior now.
so those are the things you've got to be prepared to be taking call, which, we do. We have people available on the weekends and holidays. We use mobile phones. We don't go through we do have a nurse call center for the week, but our patients can reach us. So, if you're part of a big organization, UAB or elsewhere, you're going to often get a phone tree.
Yep.
And you're going to just quit because you don't know what to do and you're panicking. And so you're going to call 911.
They don't know how to use the portal. We can do the portal, but they don't know how to use the portal.
So we really, really drive home, call us first. And we try to mitigate anything we can. And then if we do send people to the hospital, we try to direct admit instead of going through the ER. If we've seen them in the last day or two, we know they're stable, we've checked their labs, we've got their vitals, we work with the hospitalist team. So shaving that ED experience, right? And just going straight to the unit you need can help. And then we also case manage even when we're in the hospital. So our case managers and social workers are communicating with the inpatient teams to let them know what the stories are so that, they're not trying to duplicate work. And so that helps a lot because that might even just shorten the length of stay.
Sure. Absolutely. And help them create the right discharge plan because you guys are involved with
and
that
hey,
process.
you know what? You don't have to keep them 2 more days. We can check the labs at home tomorrow.
Right.
If you're just watching that sodium 1 more day, just let them go home.
Yep.
they'll eat better, sleep better, and we can check their labs.
100%.
You know.
Yep, absolutely. So criteria for house calls is, I mean, you're thinking multiple chronic complexities. Like you said, if they're showing up in a stretcher, if they're missing, if it's just difficult for not only the patient, but the whole family unit to get that person care.
Right.
They're a good candidate.
Yeah, so that's right. I mean, older, frail, functional limitations, assistive devices, you know, adaptive transportation, and then like frequent admissions to the hospital for things that are
frequent
really
flyers.
Ambulatory sensitive. I mean, some people who are in the hospital, they're going through cancer treatment, right? And they're having complications from cancer treatment, and maybe that's still what they need for a time period.
Right.
But it's different when it's that versus it's the 85-year-old with dementia who has a UTI and they go to the hospital, and then 2 weeks later they think they have another UTI, and then they go back to the that's different, right? It's that kind of thing. So yeah, those are the big things. You know, acquired disability, congenital disability. And then for our program specifically, they have to be 18 years and up. So
whenever.
Right. So currently we see people, you know, adult age.
Yeah.
But it's not only geriatrics, right? So it's 18 to end of life. And they have to live within 30 miles of the main UAB campus downtown. And people are like, oh, I'm 32 miles. But you know what? It's hard to cohort patients when you start getting out to some of those perimeters.
Right.
So to make
1 mile can take 10, 15 minutes in a back road.
So right now, because, you know, we have to be smart about how we're using the resources that we have, we have to have enough volume in a certain area to like make it work.
That makes sense.
We'd love to be able to get to everybody who needs us, and it's hard to say no.
Yeah, I'm sure.
But, you know, we also kind of manage what we can when people are on the wait list. And if we think that somebody really is ready for hospice, we also try to have that conversation with them to maybe get them to hospice sooner. I forgot to mention we work with an at-home advanced wound care company.
Oh, yeah.
Personic.
Yeah, they're great.
Yeah, they're great. So that's been a game changer, too, for a lot of our patients with, like, complex chronic wounds. So
I know there's so many new programs out there that are thinking outside the box and thinking, like, if I meet them where they are, we can provide better care and we can reduce the incredible healthcare costs that we have.
That's right. And the satisfaction of our patients is so high.
Yeah.
You know, like it's I mean, I believe we have a great team, and that's a huge part of it. I also think that they're so appreciative of having care and having people value them and see them as somebody who deserves healthcare, you know, and doesn't dismiss them. And
because in a lot of these situations, and I see this a lot in care management, it doesn't matter what the zip code is. It could be the most, 5,000 square foot house or an 800 square foot house.
Yeah.
We've seen hoarding,
for sure,
health issues, sanitary. We see that no matter what. It doesn't matter socioeconomic, but when we go in from a perspective of we're meeting them where they are.
That's right.
They may not, I mean, my house may not be, like that. I'm not saying my house is the most, specific, perfectly clean, but we meet them where they are, and there's no judgment there when you go in. Like, these people didn't get like this overnight.
That's right.
And so you and I have had this conversation a whole lot. And again, I think it comes from, decades of experience of going in and seeing people where they are, that that's something that we are teaching younger people coming into this field is we have to recognize we can't change overnight what this situation looks like. In some situations, the safest thing is to get them out of that home. But in a lot of situations, they've lived like this for a long time, and we've got to figure out how to provide that care to them in the moment where they are.
That's right. And I think that would be another really good podcast.
We
should. The social and ethical issues in home-based care.
Absolutely.
Because
that might be 3 episodes.
I know. But that's a great point, and one that like I take very seriously, that we're not here to judge you. We're not here to try to fix years of like dysfunctional family dynamics. and really that's not my job. Safety obviously is a big deal. I think that there's also like a line where people need to understand that some people may not be comfortable with a situation, right? But it's still safe. Like the patient is still safe. It just may not be like what you would do, right? And so there's a difference between safety and comfort, right?
Yes.
So a lot of people could probably agree that, you know, if you're smoking cigarettes and wearing oxygen at the same time, that's a major safety risk, right? Or if your caregiver has loaded guns in your bedroom and you have dementia, that's a safety issue.
That's not safe.
That's
That's right.
But
or
like,
we see bug infestation all over the food source or whatever else. That's not safe.
That's right. There's a ton of gray.
Yes.
And and there's a lot of reasons why people want to stay in their homes.
That's right.
And it's many times, even if it doesn't look great, it's still probably the preferred place and the place where there's still, even if the care looks different, they're going to have the most love.
Absolutely.
Because there's, just like you mentioned about the life expectancy of a caregiver, the life expectancy of a person when they enter a skilled nursing facility also goes down.
Tremendously.
So even though you think you can check the box and be like, well, now they're getting changed and
maybe,
you know, maybe, right? Maybe.
I think they were probably changed more at home.
Maybe.
But maybe their toilets cleaned a little bit more.
Correct. I mean, there's probably going to be some improvements. However, you really have to weigh it against what the harms to the patient are when they're now separated from their loved ones.
Mm-hmm.
And I think that, like, you know, I mean, it's good to be another good topic.
And you see, absolutely, you see this. I mean, there's like multiple generations that are taking care of folks. I had the opportunity to work with a young lady who has MS, along with other health issues, and her grandmother and her mom, you know, take care of her. And, you know, her home, her mobile home needs a lot of help, a lot of work. But you go in there and you can see that grandmom and mom are doing everything they can to make it as good as it possibly can be. And it's one of those situations when you go there, you feel the love. And when you're leaving, the grandmother always wants to pray. So we all hold hands and we pray. And, you know, who am I to go in and say, you know, this isn't working, that isn't working, when it is for them. Now, I would love to be able to go and get them a new one. But, you know, that's not necessarily the possibility. So that is another podcast we need to talk about.
I know. I think that, like, when you get to the place where you're making those kinds of decisions, it's, you know, there's a really good book for you guys to read. I think I told you about it. It's called The Measure of Our Age.
Yes.
But, you know, I think you have to balance the needs of the caregiver and the support structure with the needs of the patient, right? And so if you've done everything that you can to support the caregiver, giving them the resources that they need, and they're still like drowning, then it may be the thing that has to happen because their life matters too.
Right.
But, you know, if those things haven't been optimized and they're all willing to kind of work on it, then you do that. And then you know, take the goals and the preferences of the individuals and, you know, try to do what you can to make it work. Yeah.
Absolutely. Well, Taylor, I think we've got even more podcasts in the future. I mean, we have like 2 or 3 topics we've got to bring up. We need to do a book club. You and I have talked about a book club anyway.
Well, and I also want to write a book.
Yes.
So I'm pretty sure that your team would have lots of things to share.
Yes.
And we could all like co-author it.
We should absolutely.
But I want to write a book about the healthcare in America through the lens of home care medicine.
I love it. I love it. I mean, really, that's how we change we've taken decades to make this thing implode on itself. Yeah. And now we need to. It's really simple.
Yeah.
I mean, it's super simple, right? Like, meet them where they are, know what their goals are, what matters most to them. And I mean, a whole nother podcast is, like you were talking about, your mentor, is how medicine is finally looking at like falls being a criteria or even, I guess, a diagnosis code in a way, right? And all the other ones we can even talk about. And it's so important for people to understand those.
Yeah, for sure. I mean, she's also the one who, her like second wave of her career has been in looking at patient-centered outcomes of interest. So rather than, looking at, so people can kind of like align with a certain track, if you will. So your track could be, really, I just want to like have the best possible quality of life, optimize my independence and my function, but I am not interested in like highly aggressive measures to extend my life if it's without quality, right? So you can kind of be on that path, or you could be on a path that's, all things all the time. I just want to live as many days as possible, even if it means I got to be hooked up to machines, right? I am like, that's what I want, right? And then and you've got, there's probably some things in between too of like, I'm willing to do this for this long, but I think that, those are the types of conversations that they may be hard for people to have, but they're important because at the end of the day, we all are going to face the same diagnosis, and that is death.
Yeah, like everybody gets that
right,
one.
And so like we want to like have as much lifespan, right, or sorry, as much health span,
yes,
even if that means shortening lifespan, right? Because if you're alive for 90 years, but you're really only able to do things and talk and have meaningful engagement for 80 years, like who was that extra 10 years for, right? And what did it really accomplish? But like having, health for as long as possible and the least amount of morbidity before you die, I think is, it just lends itself to less suffering.
Absolutely. And I think that should be part of, and again, a whole other podcast, but we'll wrap up. That should be part of a conversation that all primary care physicians have the conversation with their patient. What does this look like? Because so often it's left for the family. And if we don't have, even with advanced directives, things can, we see it all the time. But just having that conversation of what's important to you.
And making it not about, like, the advanced directive is often about, like, the intervention at the end.
Very end.
Right? But really it should be way upstream. And it's not about, like, the intervention. It's about what is the thing that you value? Like, what is valuable to you in life? And then if that is true, what are the things that you worry about if your health changes, or what's going to be important to you if your health changes, and what are the things that you would want to put limits on, instead of saying about like code status or whatever, right?
Exactly.
Like that's just kind of like a way down the end.
And how often do we actually even use that?
Correct.
Right? It's all the things before, like you mentioned. 100%. So, well, we're going to have more podcasts. Yay!
That was fun.
I think Taylor probably wrote down several different ones that we're going to have. So again, thank you.
Yeah, thank you for having me.
Love all the tidbits that you gave us, and again, it goes back to kind of like the basic Maslow's hierarchy of needs. Let's just go to the basics. Start there, and then go, because we can't get to self-actualization if the basics, where I'm going to find my next plate, my next food, and safety and warmth are not taken care of. So it's crazy how that triangle is, embedded in everything that we do.
That's right.
So anyway, well, again, I'm so glad you got to be on here with us.
This was fun.
Always fun. Yeah. I know everybody's going to like, subscribe, and follow. So again, like this podcast on Spotify, Apple, YouTube, all the things. Use the little arrow button to send it to all your folks. You can share, you can follow, you can do all those things. But again, thank you for listening and watching Aging Uncensored with our special guest, Dr. Marianthe Grammas. And tune into the next one. Thank you.
Awesome. Thank you.